All right, great. Thank you everybody for joining us this morning for our seminar and webinar on aged care. It's a very chilly morning in Melbourne, and thank you for joining us so early. It's my pleasure to introduce our very first speaker, our very own Noleen Bennett. She is a Senior Infection Control Consultant at both the NCAS and the Victorian Healthcare Associated Infection Surveillance System Coordinator Centre, or also known as VICNISS. At NCAS, she oversees the Aged Care National Antimicrobial Prescribing Survey, and she is a Chief Investigator for the MRFF research project titled Development and Implementation of a National Infection Surveillance Program for Aged Care. Today, she'll be presenting about adoption of a Delphi technique to achieve consensus for a national infection and antimicrobial use surveillance program in Australian residential aged care homes. So over to you, Noleen.
Thanks, Josephine. And I'm in Melbourne too, and so I'll try not to shiver as I talk. So we'll just get... Okay. We'll just start with what you already know, just some background information, and that's that residents in residential aged care homes are vulnerable to acquiring infections. That infection and antimicrobial use surveillance is an important part of an infection prevention and control program. In Australia, there are currently no comprehensive nationally coordinated residential aged care home infection and antimicrobial use surveillance program. A national program would enable standardised measurement across Australian residential aged care homes and allow for benchmarking to understand and compare performance. As I said, what you already know. So the NISPAC aims, it's because of that background that a research grant was awarded for the development, the implementation and evaluation of the National Infection Surveillance Program for Aged Care. The aims of NISPAC are to develop a comprehensive and useful infection and antimicrobial surveillance program to ensure this national program is both effective and efficient, and to provide a dedicated and secure IT platform that enables straightforward participation. The research grant is being overseen by the VICNISS Coordinating Centre, NCAS, and the Registry of Senior Australians, ROSA. So to meet the NISPAC research objects, the working plan has been divided into 3 stages. Stage 1, investigation; 2, development; 3, implementation. This is alongside economic and data linkage studies. The NISPAC IT platform is currently being built. The pilot NISPAC program is scheduled to commence in July. But for the presentation, I'm going to be talking about the Delphi surveys that have been completed as part of stage 2 and development. But before I do, just quickly, I just want to show you what the NISPAC platform looks like. This will be officially launched in mid-July. And just a little bit quickly about the NISPAC program. In addition to new surveillance modules and infection prevention control and AMS resources, the NISPAC pilot program will incorporate revised versions of 2 existing surveillance programs. They are the VICNISS Infection Indicator Program, up until now only available to the public residential aged care homes in Victoria, and the Aged Care National Antimicrobial Prescribing Point Prevalence Survey, available to all Australian residential aged care homes. But about the Delphi survey. Delphi survey is a well-established approach for experts to answer research questions and identify a consensus view. Our aim was over 3 surveys to gain consensus about potential NISPAC program options. National and international experts in aged care, infection prevention control, ID, AMS, pharmacy and clinical microbiology agreed to participate. I so wish it was appropriate for me to tell you who those experts were. All I can say is they are truly experts in their fields. Each of the 3 surveys were divided into 3 sections: surveillance framework, process measures, and infection definitions. And within these sections, subsections and program options. In all surveys, the experts were asked if important to include for all surveillance framework and process measure options. In all surveys, the experts were asked if appropriate to include for all infection definition criteria options. For surveys 2 and 3 only, feasible to include was also asked for all options. In survey 1, the experts were required to respond to the questions important or appropriate to include using a 5-point Likert scale. In surveys 2 and 3, the experts were required to respond to the questions important, appropriate, or feasible to include using either a 2 or 5-point Likert scale. Agree was defined as an agree or strongly agree response on the 5-point Likert scale or agree response on the 2-point Likert scale. So, for example, in survey 1, important to include was asked for each of the 15 potential infection module options. In survey 1, important to include was asked each for the 8 potential options to determine antimicrobial appropriateness. Another example, in survey 1, appropriate to include was asked for each of the potential UTI without a catheter, clinical and microbiological surveillance definition options. Now, this is the slide where I have to concentrate too. For each option, the number of agreed responses was totaled, and the agreement level classified as consensus if greater than or equal to 90% for surveys 2 and 3, high if greater than or equal to 75% for survey 1 or between 75 and 89% for surveys 2 and 3, moderate if between 31 to 74% for all surveys, or low if equal to or less than 30% for all surveys. Questions were excluded if the agreement level was consensual after survey 2 and 3 or low after surveys 1, 2 and 3. So we'll now look at some results. So for the surveillance framework potential options, there was consensus amongst the expert. It is most important to include C. difficile, gastroenteritis, influenza-like illness, norovirus, pneumonia, urinary tract infection modules. To include C. difficile, E. coli, influenza, Klebsiella, norovirus, RSV, COVID, and Staph aureus organism modules. That we collect clinical and microbiology criteria, and that we look to monitor all isolates and specific isolates responsible for outbreaks. If we just drill down for a moment to the infection module data, this shows for 5 infection module options, there was consensus amongst the experts that they were important and feasible to include. But interestingly, for the pneumonia module, whilst there was consensus that it was important to include, the experts considered it was not feasible to include. Okay, some more results. For the process measures potential options, there was consensus amongst the expert it is most important to include COVID-19 influenza vaccination for staff, COVID-19 influenza pneumococcal vaccination compliance for residents, that we look to measure in determining antimicrobial appropriateness the presence of defined clinical signs and symptoms, presence of devices and previous recent antimicrobial therapy. And that for hand hygiene, we look to measure competency and undertake some observational compliance, somewhat similar to what we do in our hospitals. So if we just drill down here and look more closely at the antimicrobial appropriateness data, we find that there was clearly consensus that the presence of defined clinical signs and symptoms, the presence of devices, and the previous recent antimicrobial therapy should be measured. In fact, by survey 2, we were well above 96%, ranging from 96.7% to 100%. Okay, for the 7 infections or constitutional criteria. By constitutional criteria, what I mean is just general criteria like fever, change in functional status, behavioural change, that may be typical of many different infection types. What we found was that there was consensus amongst the expert that it's most appropriate to include or use the Stone revised McGeer et al. Definitions. But that for 4 infections or constitutional criteria, there was consensus that it's more appropriate to use alternative definitions. Just ironically, as a side, the widely referenced McGeer definitions, specifically for use in long-term care facilities, developed in 1989, published in 1991 and revised in 2012, they were actually developed at a consensus conference using the Delphi technique amongst the conference participants. So what you're looking again is at the slide that I showed you earlier. This is the NISPAC pilot program, and I'm re-showing you this slide because I want to just highlight what we're doing because of a result of having undertaken the Delphi surveys. That is, we're actually looking at the results from the Delphi survey and looking to incorporate them into the pilot program. So as a consequence, we have now added a resident COVID-19 module, vaccination compliance module. We have developed a new UTI surveillance module. For the definition infections for the aged care NAPs, we will be looking to modify somewhat the infection definitions, so they won't all be based on the Stone McGeer definitions, and that we will be looking very closely at antimicrobial appropriateness. The aged care NAPs, as many of you are aware, or all NAPs, is currently being rebuilt. So for this slide, just in case nobody asks me any questions at the end, I'm going to ask myself some questions and then look to answer them. So, well, why did the experts agree a pneumonia surveillance module was important to include but not feasible? My answer to that is in Australian residential aged care homes, it's not routine that chest x-rays are undertaken. And so I dare say this is what the experts were thinking when they were looking to score whether this particular module would be feasible to include. Another question that I might ask myself, I think, you know, you too might be thinking, well, why are gastroenteritis and neurovirus infection surveillance modules not included in the NISPAC program, even though there was agreement that they should be in the surveillance program? Our answer to that is at this stage that we believe that in most states and territories that the public health units well and truly oversee any gastro outbreaks, norovirus outbreaks. And so any work that we might be doing in collecting data would be duplicating what they're already doing. So hence, not included in the pilot program. Another question you might be asking is, can our residential aged care home participate in the NISPAC pilot program? The answer to that is we've been overwhelmed by interest, but there's still a few limited number of places left for those that may wish to participate. If you are interested in, I say to you, quick, email us on nispac@mh.org.au before June the 30th, and you might be lucky to be able to participate. If I can emphasise too, you don't need to be have undertaken surveillance before. If you're new to it, we welcome you. Alongside those that have been doing surveillance for a long time. We want all levels of experience to be participating in our NISPAC pilot program. A launch information session is to be held next Tuesday at 2 p.m. So many to thank, but especially the aged care infection prevention control staff that sit on our consumer and community committee. Their feedback is invaluable, and all the staff that have participated in NISPAC, VICNISS, NCAS and ROSA initiatives over many years. Also, just want to thank Anna, who had previously undertaken a Delphi, Anna with her co-authors here, had previously undertaken a Delphi survey to when we did it, and was able to share with us all the tips about undertaking a Delphi survey. It's not as easy as you might think. So thank you, Anna, for all those tips. And just lastly, if you like further information about NISPAC, as I said, the website, mid-July, the official launch of that website. You can actually access it already, but just be mindful that the official launch, there's still a bit of work to be done mid-July. You can email us always, and we have published some of our work. Most recently, the point prevalence studies of healthcare-associated infections in long-term care facilities, a systematic review and meta-analysis. That's me. Thank you, Josephine.
Thank you, Noleen, for that presentation. That was very informative. We've got some time for questions before we start the next set of presentations. I actually have a question before I hand it over to the floor, but you mentioned a lot about the NISPAC program. Am I right in saying that all states and jurisdictions in Australia can participate, or is this limited to certain states?
No, absolutely. In fact, we want representation from all states and territories. We want representations from public, private, not-for-profit. We want representations from those in remote areas, in metropolitan areas. We want representation from small, 10 beds up to, 500 beds. We want everyone to participate. And with that, if you're interested, if you send to that email, I'll send you back in detail what it incorporates, what it means. But I like to think that in participating, it's not just, importantly informing us, but that we will be able to support you in your surveillance activities. So thanks, Josephine.
Okay, great. We've got some questions from the audience. They're all coming through now. So the very first question is from Philip. Is the UTI surveillance point prevalence or incidence?
No, good question. It's incidence, so it's a continuous module. It's based on the CDC long-term care facility module. It's looking to, that it's incidence, it's looking to measure all new UTIs. So that's because it's new. It's one that we'll be very closely looking at, and to see if it works or doesn't work. How difficult it is to implement a UTI surveillance module, continuous incident UTI module.
Yep, great. The next question is from Christine Hunt. If an RACF starts in the pilot but for some reason wishes to withdraw, is this possible?
Absolutely. And in fact, that's feedback in itself, isn't it? Why did they need to withdraw? Was it too onerous? Was it, that would be important feedback if somebody started and needed to withdraw. So yeah, Christine, please, everyone can start. We hope everyone finishes, but yeah, all welcome.
The next question is the CDC NHSN long-term care facility manual available to access?
That is online. The thing with the CDC long-term care facility manual is the thing that we have to be mindful of, and this is where why we have been so comprehensive in developing our surveillance program, is that it's not automatic, it's not absolute that what they are doing in the US or elsewhere, with that CDC long-term care model is applicable to our residential aged care homes. Their long-term care facilities are slightly different to ours. And if I put it simply, one of the main differences is that they often have what you might call more acute patients combined with the residents as we know residents in our residential aged care homes. So it is accessible. You can go onto the CDC line, but just I caution you to be very careful how applicable it is to ours. And that's why we're modifying, while we're spending so much time making sure that anything surveillance we do is really useful, applicable to our facilities.
We've got a question from Christian. Is pathology or testing also captured in the program and aligned with antimicrobial use?
Yeah, good question. For the different modules, not all of them, it's obvious which modules. We do look to collect biological data, and that came through strongly that it should be a combination of clinical first and foremost, but where applicable, microbiology criteria too. So for those modules, residential aged care homes should have in place a system that they can access that data, which can sometimes be tricky, I understand. Around antimicrobial, then that leads us into antimicrobial appropriateness. That's where the team at NCAS, we are sitting down now, looking very closely at, how we can match that. Also, how we can match the antimicrobial use data against compliance with guidelines and, other measurements around appropriateness.
Great. The next question is, how will the pilot be evaluated?
Yes. Well, there's lots of steps along the way that we're evaluating, and one of them is cost. So how much time does it take to do surveillance? And so we've got an economist in place to do that, because that's that'll probably be the first question our managers in residential aged care homes, rightfully, alongside the Commonwealth, will ask, how much does it cost to undertake this surveillance? So that's one part of our evaluation. Another part is just simply looking at, are we applying the definitions correctly? Are we able to measure these different data fields that we've outlined? So there's lots of opportunities for, interviewing the staff, both formally and informally, feedback. So, yeah, the evaluation, and, that's really why this is considered a pilot, because we will be evaluating very closely.
Right. We've got a question from Ruby. How do you determine what and how much to implement from a Delphi survey?
Just ask me that one again, Josephine. How much do we...
How do you determine what and how much to implement from a Delphi survey?
Yeah, good question. So, because undertaking the Delphi was a huge effort, and so from that, you want to consider and take time to, what you're going to include and not include. So some of the results, I have to say, we were a little bit surprised about. And one of those is just how gastroenteritis featured so prominently. The working party that we've got another series of working parties made up of experts that are looking at those results and then taking into account other factors like what I highlighted for gastroenteritis, that, we were able to sort of sit down and discuss through the public health unit involvement in that space. And so it's just a series of working parties considering, again, made up of experts, what we consider experts, as to, whether we'll apply them. The other thing to add with the application of the results is, we're applying for the pilot phase, but that's not to say we won't come back to the Delphi results. We'll just keep coming back and cross-checking. Our pilot we consider as a stage one, step one in the implementation. It's, everything we do now is not the end. Everything's evolving.
The next question is from Carrie. How was the choice of staff vaccination review established? For example, influenza, COVID, and hepatitis B.
Yeah, well, the hepatitis B didn't, for our aged care staff, there wasn't a consensus agreement to include it, which is a little bit surprising. That was I would expect down the track that will be included, because we know it's recommended for these staff. But just as a starting point, we just felt influenza and for the residents, as I highlighted, COVID, Herbicide, pneumococcal, and what have I missed? COVID, influenza, herpes zoster, and pneumococcal. Yeah, 4 for the residents and 1 for the staff at this stage. I guess the thing is, we just wanted to be a bit careful too that we don't come on overwhelmingly, with everything in one go for the pilot. We want to set up and just check how well we do a sample, and then I dare say as we go forth, we'll extend the program and include hepatitis B, certainly. Kerry, good question. It was interesting that just didn't highlight from the experts. I guess they were looking the most important, and needless to say, in recent years, respiratory vaccinations have rated highly. Yeah.
Another question from Kirsten is, how did you develop the categories of consensus, high, moderate, etc.?
Yeah, that was, we worked, as I said, during the presentation, we worked with Anna, and we went and looked at the literature, what had previously been put forth as consensus around those percentages. So probably you could argue a little bit arbitrary, but we certainly went back to the literature and looked what previously had been done around how to define those percentages for consensus.
Okay, those are all the questions that we've got so far. We've probably got time for 1 or 2 more questions. If anyone wanted to be unmuted, we can do so and allow you to ask the questions live. Otherwise, please feel free to type it into the chat box.
I can see just one comment's come through, sharing the slides, that's fine, and or just say the recording's available online. At this stage, probably from this presentation, it will only be the recording. We are looking to publish this work. So for the moment, just the recording. But if you have any questions, like always, you're always welcome to contact us and ask more questions. So maybe, Josephine, we can leave it at that and just say, because if you're like me, I always think later, I should have asked. So you're always welcome to contact us.
Okay, great. We're right on time. So what I'll do is I'll move on to the next presentations. We've got about 30 people that have joined us since we introduced today's webinar. So I'll just give myself a very quick introduction and introduce our next set of speakers. My name is Josephine, and I'm an AMS antimicrobial stewardship pharmacist here at the National Centre for Antimicrobial Use. And it's my pleasure to introduce our next 2 speakers. We've got, sorry if I mispronounce your name, Mr. Yohanes Wondimkun. He is a PhD candidate at the University of South Australia, and his PhD research focuses primarily on improving the use of diabetes medicines amongst older people living in aged care homes, using a linked health and aged care data from the ROSA. Yohanes also works as a research assistant on the NCAS project. And Janet Sluggett, our second speaker, is an associate professor in pharmacy and pharmacoepidemiology at the University of South Australia, and she is an NHMRC Emerging Leadership Fellow. She's an affiliated postdoctoral researcher with the Registry of Senior Australians at SAHMRI, which stands for South Australia Health and Medical Research Institute. And her research seeks to improve medicine's use, safety, and effectiveness in older people accessing aged care services. I'll get you both to share your slides now. Okay, great. And the presentation is on trends and variations in antimicrobial use and microbiology testing in Australian aged care homes. Over to you both now.
Excellent. Thanks very much, Josephine. And thank you, Noleen, for a great presentation. And thank you to your team for the opportunity to present with you today. And we're presenting some early results from our involvement in the NCAS project. So we're quite excited to be able to share them with you today. So in terms of the outline for today, I'll give a bit of a background on some of the background work that we've done looking at antimicrobial use across all...
Janet, your slides, we're still on the first slide and it's not in presentation mode either.
Oh, okay. We'll just try and reshare on the other screen. How's that going,
Great.
Josephine?
Yeah, we can see your presentation outline slide now. Yeah,
Perfect.
that works.
Excellent. Thank you. So I'll just give a bit of background about some of the work that we've done using real-world data, looking at antimicrobial use across all Australian aged care homes, and give an introduction to some of the work that we're doing as part of the NISPAC project. And then I'll pass on to Yohanes, and Yohanes will provide us with an overview of a recent study that we've completed looking at microbiological testing in aged care homes. And then we'll discuss those findings and talk about our next plans for work in this area. So I just wanted to start by mentioning the data source that we use for our research, which is the Registry of Senior Australians. And so this is a national aged care registry. It's a linked health and aged care data platform, and it really helps us to monitor medication use, health service use, mortality, and other types of health outcomes for all older people who access aged care services in Australia. So currently the ROSA data includes all individuals who've ever had an aged care assessment or accessed aged care services between 2002 and 2022. And so there's data for more than 3.5 million older people who've accessed any type of aged care service. And this is really important repository. The data is linked at an individual person level, and it pulls together these different data sets so that we can really understand the aged care and healthcare, I guess, service use and pathway for these people who are having contact with the aged care system in Australia. So we've done a number of studies using data from ROSA to look at antimicrobial use across Australian aged care homes. So we've done a couple of studies looking at trends in use from 2005 to 2015, and then this second study now looking at trends between 2015 and 2019. We've also done some studies looking at how antimicrobial use varies across aged care homes nationally. So there's substantial variation in use across aged care homes. Just to highlight the results of this particular study, which looked at the prevalence of antimicrobial use in aged care homes over a 12-month period, repeated annually. And what we found was that there really has been very little difference in antimicrobial use. Nearly 70% of residents receive at least one antimicrobial, and they are dispensed a median of 3 prescriptions. So they're often receiving multiple courses of antimicrobials during that year period. So quite a high burden of use. And I guess that's what initially led us to start working with Noleen and Kaz and Leon and their teams around the NISPAC project. And I think Noleen's provided a fantastic overview of the NISPAC project and has made some really fantastic achievements thus far. We can see that our work plan for the project is along the bottom here. And really, we're interested in using data from ROSA, this real-world data, to understand antimicrobial use, microbiology testing, hospitalisations for infectious diseases. So this can feed into the development of NISPAC and the evaluation as well, particularly from a health economics point of view. You know, if we're able to target some of these things with NISPAC, what are some of the changes and impacts that we might see over time? So what research are we doing with NISPAC? We have a series of 4 studies that we're undertaking. The first one is looking at annual trends in the prevalence of microbiology testing and also how testing rates vary among different aged care homes. And that's the study that we're going to present today. We're also doing a piece of work next which focuses on, well, okay, someone's starting an antibiotic, but do they have microbiology testing around the time that an antibiotic is initiated? So that will be a second piece of work that we undertake. We'll do another study looking at incidence of hospitalisations for infectious diseases and associated factors among residents of aged care homes. And then finally, we're in the process of, at the moment, linking in participation data from the VICNISS and ACNAPS programs into the Registry of Senior Australians, so that we can do some investigation into whether, you know, if you're participating in these programs over a number of years, is there a difference in antimicrobial use, microbiology testing, or hospitalisations for infections in those facilities that participate compared to those that don't participate? So we're really looking forward to working through this body of work and contributing to NISPAC. So I guess we've become, when we've been focusing on antimicrobials, we're also interested in microbiology testing and accompanying that. And so there are a couple of standards available which suggest that, you know, when a person is started on an antimicrobial before they're started, that it's important to obtain appropriate samples for microbiology testing when it's clinically indicated. And on the right-hand side, we can see that Choosing Wisely Australia also has a number of recommendations that relate to microbiology testing in people who have infectious diseases. And so I guess that has led us to this first study looking at microbiology testing in aged care homes. So I'll pass on to Yohanes to speak more with us about that project.
Thank you, Janet. Thank you, everyone. On this part of the presentation, I will briefly go through the objectives, methods section, and I'll try to focus on result and discussion, and we'll have some conclusive statement as well. So this study, this particular study has three objectives. The first one is to examine annual trends in microbiology testing among residents of Australian aged care homes between 2009 and 2019. Second one, to examine microbiology test requests on the same day within 7 and 14 days of an initial test in aged care homes. This is in 2019. And another is to examine variation in microbiology testing by aged care homes. The analysis is in progress for this one. The first, second, and third objective is for 2019. Moving on to method section, we conducted a repeated cross-sectional study using linked health and aged care data from National Historical Court of Register of Senior Australians. The study cohort included non-Indigenous individual aged between 65 and 105 years. We were not able to include Indigenous people due to ethics reason. We also excluded people who access Department of Veterans Affairs subsidized aged care because they access the MBS service differently. And we included people who accessed the service permanently, that's over 100 days between 2009 and 2019. The main outcomes of the interest of this study is annual aged and sex standardized trends in prevalence of microbiology testing and the number of microbiology tests claimed per 100 resident years, and percentage of microbiology tests co-ordered. We identified selected pathology tests under MBS group P3 and P9 requests from aged care homes from MBS claim data. We excluded hospital inpatient claims to keep these claims to aged care homes. We categorized these tests as urine, skin or superficial, fecal, respiratory, ENT, that's tests pertaining to ear, eye, nose, and throats, genital, blood, and also we include some pathogen targeted tests like Cryptosporidium and Giardia, like chlamydia or C. difficile. And also we had non-specific group. This test mainly involves tests for virus or microbial antigen or nucleic acid tests. Bit about statistical analysis. The prevalence in microbiology testing and number of tests per 100 resident days each year was standardized for age and sex using direct standardization. Adjusted proportion rate ratios with 95% confidence intervals were estimated using Poisson regression models. Combination of microbiology tests claimed on the same day in 2019 were presented using heat maps. So I move to the results. This table shows you selected individual characteristic for overall cohorts, that's from 2009 to 2019, and for selected study years. So you can see in the second column, we do have overall cohort characteristics. And then you see 2009, that's the start of the study, 2014, that's the middle of the study, 2019, that's the end of the study period. So in the first row, number of residents we include in this cohort overall is over 500,000. That's large sample size. And each year we include around 150,000 to 200,000 just sample range yearly. So the median age of the residents is 84 years, female accounting 2/3 of the cohort. When you see the health condition of participants, the median comorbidity was 5, and over 50% of the residents had dementia, and while one in 4 of residents has diabetes. So on this part of this, this table shows you age and sex standardized prevalence of microbiology testing, again, overall and for selected study years. And the first column, you see tests, in the first row, all tests, and in the subsequent rows, tests by type. The second column shows you overall cohort prevalence of testing, then subsequent column in 2009, 2014, 2019. The last column is adjusted prevalence rate ratio, which shows us the average annual increment or changes. So for example, in the first row, when we see all tests, we see that at least 80%, nearly 80% of individuals had at least one test during the study period. When we see annually, this is 50% prevalence in 2009, and it increased to 59% in 2019. When we see the adjusted rate ratios, that's 2% increment yearly. So we see on the second row, urine is the most dominant test, about 2/3 of the residents having at least once this test overall, and annually, this was 41% in 2009, and 2019, it was increased to 45%. That's 1% increment a year. So we see non-specific test is the second most dominant test. So this figure shows you basically the same data we presented on the previous slide, but this time unadjusted crude trend yearly is presented visually. You can see there is small increment ranging from 1% to 2% overall, except for this black line, which represents non-specific test, which is dominantly micromolecular tests. So it's interesting, you see this test specifically increased dramatically during the study period, and in 2018 it dropped suddenly. So this test drop in 2018 might be related to suggestion from MBS review task that come in 2017, which suggested restructuring of this current generic MBS tests into system-based structure. That might have affected that, but we are further looking into how this report may have affected this change for a specific test. So in this section, we have the prevalence of microbiological testing stratified by sex in the first figure, dementia and diabetes conditions. You see female have more tests compared to male in the first figure. This is because driven mainly by a urine test. As we know, the female has that increased risk of urinary tract infections that might have led to this finding. On the dementia, we see that people without dementia had more tests than with dementia. This is interesting finding because otherwise we may expect people with dementia will have more tests given their frailty. As expected, people with diabetes have more tests than people without diabetes. That's given that they have more risk of infection. This is expected finding. So briefly on this one table, you see it is number of microbiology test per 100 resident years. This is to consider all tests because people may have more than one test during the study period. So you see in the first row, for example, for overall cohort, 196.3 microbiology tests per 100 resident years was conducted. That means nearly each individual had 2 microbiology tests a year. That's what's showing us. And on the last column, you see that in overall, the number of tests per 100 resident years increased by 3%. This is more increments than the prevalence increment we have seen earlier. So this figure shows percentage of frequently requested microbiology tests that were requested on the same date with the test in row in 2019. So for example, you see fecal tests in the column. That's 74% of fecal tests were conducted with on the same date with non-specific tests. In the same line, 61% of fecal tests was conducted on the same date with cryptosporidium or Giardia tests. You see urine test, which is most common one, is not less, it has less percentage of that co-requesting, and it's not that it was not tested together, but this is because it's high volume, and when we compare with other tests, that percentage come very less. Otherwise, we see hepatitis test, C. difficile test, chlamydia test, these are most likely to be co-ordered with many specific tests. This is mostly molecular tests. So moving into discussion point, I just highlight few points. We know that more than half of the residents received at least one microbiology test each year, which is increment by 2% annually. And the most common tests were urine and any specific tests as skin tests. From Aged Care National Antimicrobial Prescribing Survey, which is conducted in single day, we know that most common infection were skin, followed by respiratory and urinary tract infection. So our finding in terms of the burden of tests is not in alignment with this survey. So when you see urine, the most common test, that's urine testing. And there is also increments. This is not unexpected given older age of our cohort, who are predominantly female. And this is also in keeping with previous UK primary study, which found that urine tests were most common request tests. However, our finding is not in agreement with a study from US, which reported decrease in urine culture testing, even though this is specifically urine culture, we see that decrement from that study. We know that from previous study in Australia, urine over testing is common, specifically dipstick testing, which might lead to inappropriate antimicrobial use. Another interesting finding is that tests for microbial or virus antigen or microbial nucleic acid test, the most common one, and it's increased substantially during our study period. This might be due to relative use of this relative ease of use, improved turnaround, and increased sensitivity of this test compared to traditional methods such as culture. We know that fecal, respiratory, ENT, and other pathogen targeted tests were most commonly requested with these tests. And to some extent, this is justifiable because traditional methods like culture can be requested concurrently with this molecular testing to detect antimicrobial susceptibility or to detect virulence of the microbes. So just the strengths and limitation of this study. the strength of this study is this is the first study to examine microbiological testing across all Australian aged care homes using National Comprehensive Linked Health and Aged Care data spanning an 11-year period. We may have estimated microbiological testing, underestimated microbiological testing, as only 3 most expensive pathology tests can be claimed on the same day. Also, another limitation is we excluded microbiology tests performed for public inpatient surveys, which might have shown us different picture. Also, we were unable to evaluate the appropriateness of the test performed and the outcomes of the test, nor the types of organism identified. So what's the key takeaways from this finding? More than half of the residents of aged care home have at least 1 microbial test annually, increasing from 50 to 59% between 2019. The prevalence of urine testing is high in aged care home, increasing from 41% to 45% during our study period. There was marked increase in tests for molecular testing, increasing from 6 to 20% over 11-year study period, with this test commonly co-requested with other microbiology tests. Microbial tests are important for informing empiric antimicrobial use. However, it is important to avoid unnecessary testing to reduce burden on residents and healthcare system. So finally, the next step is to see prevalence and correlate of microbiological testing around the time of systemic antimicrobial antibiotics initiation among residents of aged care homes. I would like to acknowledge the collaborator and everyone involved in this project, and thank you very much.
Thanks, Yohanes, and thanks, Josephine. We're happy to take some questions.
Great, thank you for that presentation. That was very informative, and I'm sure we've all learned a lot about microbiology testing in aged care homes. We've got a lot of questions that have come through. The first one is from Ree. Her question is, does antimicrobial use data in ROSA allow for differentiation between systemic and topical applications?
It does, but we're limited by the fact that we can only pick up medicines dispensed on the PBS or that are under the PBS subsidy. And so a lot of topical antimicrobials that we're concerned about in aged care homes are obviously topical antifungals, and they're most commonly purchased over the counter without a prescription. So unfortunately, we don't have that really good capture of topical antifungals, for example.
Great, thank you. We've got a question from Dipti. It would be interesting to see how COVID-19 impacted prevalence of microbiology testing in aged care homes. And her question is whether a follow-up study would be considered to evaluate this.
Yeah, definitely. I think one of the challenges working with these linked health data sets is they've got very rich and powerful information, but there's always a time lag with all of the linkage that needs to be done and the provision of that data. So, you know, we've just had literally in the last couple of months the data updated to the end of 2022. So we are really interested in seeing now what the effects of COVID have been on a number of factors across the aged care system, including antimicrobial use and testing. So definitely more to come.
We have a question from Christian. He's very surprised about the low rate of respiratory testing in this data. And do you know whether there could be any reasons contributing to this?
Respiratory testing is low partly because we don't test like some respiratory infections are viral, and some of testing is not recommended for these conditions. Partly this could be a reason.
Yeah, I think thanks for your question, Christian. I think that's something we should look a bit more into. I wonder if it's in partly because we've excluded tests that were performed in the hospital setting. So we're missing all of those tests that might be for respiratory infections. And off the top of my head, I'm not sure what the price of the respiratory tests are compared to the other tests. And so I can go back and look at that. But because the pathology companies are only allowed to claim the top 3 most expensive tests, that could have something to do with that as well.
Murray had a question around testing done outside of the MBS, and you've kind of touched on that with Christian's question as well.
Yeah, that's right. That's another important limitation, that we're just not able to see testing outside the MBS.
Okay. Those are all the questions we've had in the questions and answers. Oh, I see Courtney's got her hand up.
Sorry, because I'm a panelist, I can't actually ask a question in the Q&A. I guess a parallel of diagnostics and microbiology tests to antimicrobial stewardship is, AMS has come a long way. And at first, we started out with consumption data, and now we do have quality data. So you mentioned that, your data identify that over the years testing has increased, but are there any insights, or how do we know that it's increased, but, that it's clinically appropriate and that it's warranted? Or is it just increasing and it's like, how do we know whether that's a concern or not? And I guess that's where that concept of diagnostic stewardship comes in. Yeah, thank you.
Yeah, definitely. I think just emphasising that this is our first step in a series of projects. And so in our next study, we'll be looking at the time point of when an antibiotic is initiated, and then is there testing on the same day or within 7 days or within 14 days of that antimicrobial being initiated. And so that will tell us a bit more about the appropriateness of testing. And then I think in that final study where we start looking at trends in infectious diseases, hospitalisations, in antimicrobial use, and also microbiology testing in facilities that do overall across all aged care homes with updated data to 2022, but then also split by whether they participate in the ACNAPS VICNISS programs. I think that's going to then, when we can see that picture of all of the different markers across time, will give us also a bit more information about appropriateness and where it's heading. Thank you.
Thank you, Janet. We've got 2 final questions. The first one is around the availability of RAT testing in aged care homes and whether you think that will impact data in the future.
Yeah, that's a good question. I guess we wouldn't be able to pick that up in our data because we'll only pick up the claims on the MBS. So, I think it will be interesting definitely to see what happens with those respiratory tests, and going back to the previous question as well, particularly during COVID, whether we see differences in that.
Great. And our very last question is from Carrie. It's understood that dipstick testing in this timeframe has high use. Do you think it will drop now with the aged care dip or not to dip resources available?
I think a paper has just been published on the outcomes of some of the early work with the dip, to dip or not to dip. So I think, I look forward to seeing more outcomes from that. And yeah, I guess unfortunately we can't pick up the dipstick testing in our data, but we'll certainly be able to look in some of our subsequent studies how urine cultures have changed from that sort of 2019 period to 2022 period. So we'll keep an eye out for that as well.
Okay, great. We're right on time. I would like to thank our 3 excellent speakers again for your very informative sessions today. And Courtney, I'll hand over back to you to talk about the next month's seminar topic.
Thanks, Josephine, and thanks everyone. Just great to see we had about just under 100 people online today, which just shows how important it is that we provide our education to our aged care clinicians. Next month, last year we ran an implementation science workshop in person. We will be running that forum again this year, but online. So July will be all about implementation science and how to apply those principles to quality improvement for antimicrobial stewardship. It is intended at a higher level that would be applicable to hospitals, aged care, One Health perspective. So it's not just a hospital focused talk. Professor Denise O'Connor will be running that session. And also we are developing a program for Antimicrobial Awareness Week. It will be an in-person only event in Melbourne on Friday, the 23rd of November, I'm pretty sure. But watch that. We'll have all that information out soon. As always, our NCAS newsletter, NAPS newsletter, we'll have all that information. And if you keep an eye out, by the end of the week, the recording of this talk will be on the NCAS website as well. So thank you so much and see you next month. Bye.